Hi folks, this is Hariom for CBNA. Today, as we have promised, we are going to answer questions on task-oriented approach or task-oriented exercise or functional activity-based approach. There was around 27 questions. Some of them were overlapping, so I have sort of put it all together, right? So some of it will be individual questions, some of it will be a bunch of questions, so we'll have the same answer for that. So we will go to the first question. So there are a bunch of questions. Basically what they have asked is, if there is no activity, right, if the muscle power is less, if it is flaccid, or if it is very chronic and there is no muscle activity, if there is severe cognitive dysfunction, all these things we have put it together, right? And what the question I have formed for all these things is what to do when there is no activity in the muscles, right? This is a very common question they ask for in case of task-oriented approach. Not only task-oriented approach, any exercise, I suppose. Now, the first thing you want to understand is, in case of less muscle activity or no muscle activity, it should be easy or it should be possible for us to, especially in the acute stage, it should be possible for us to make him sit, even to some extent stand, and things like that should be possible. So that is one point of it. But in case of upper limb, right, if there is no activity in the fingers or in the shoulders and things like that, if there is no activity, there is no treatment options, whether it is task-oriented approach or any approach, you can't do anything. Say for example, because there is no activity here, one possibility is you can only do passive treatments. Passive treatments, as we have already we all know, that doesn't produce any improvement in our patients because it does not change your brain, so it is of lesser value. So the simplest answer for that is, if there is no activity in my upper limb, very difficult to do any exercise. In case of lower limb, because only one muscles or only one limb is affected, you can make him stand, to some extent make him walk, sitting, all these things should be easier. And some of them asked, what if I have grade 2 or 3 muscle power, right? In case of upper limb, if it is 2 and 3, it is easy to formulate a lot of task-oriented approach exercise, as we do for re-education of muscles from 2 to 3. You can do with your re-education board, you can do pointing task, you can do reaching task, all these things in a horizontal plane, we can do that. So I hope that answers that. The next question is, there are two questions. Again, I have combined these two together. They have asked, what do you feel does the attender or the caregiver accepts or satisfied with the active or assisted exercise? Basically what they are asking, I think there is some grammatical error in the question, but basically they are asking is how to make your caregivers accept sort of an active program where we are touching the patients less, I suppose, and we are telling them what to do. And the next question is, why do patient caregivers give more importance to sort of limb movements, that is getting this or getting dorsiflexion and things like that. So basically what I think is how to educate the caregivers about or what to educate the caregivers. Extensively, Mr. Vasantan is working in this area. There are obtain amount of literature on how to educate your patient as well as how to educate the caregivers. But just to give a glimpse of it, the simple example I tell any patient is, if you have a son or a daughter, right, if they have to study well, it's of lesser value if the parents keep on yapping about that, go and study, go and study, go and study, rather than the patient has to understand, the student has to read. Whatever we say is go and study, does not help him study better, right? The patient has to do it by himself to get better. So we need a good education program. I'm not getting into the details of how to do that education program, because there are theoretical ideas and there are lots and lots of literature you can go and see. But the bottom line is, educate your patient about the value of active exercise and how that is going to improve. That is the bottom line, I think. Right. The next question is, how can you train dorsiflexion in a functional task? This question itself is sort of an oxymoron, I suppose. By definition, a task-oriented or a functional activity is multi-jointed movement. It is not individual movement like dorsiflexion or something like that. So we don't look into improving dorsiflexion or plantar flexion or things like that. We look into improving flexion. We look into improving gait. We look into improving balance, things like that, rather than this just dorsiflexion or wrist movements or finger movements or things like that, right? Okay, this is a very interesting question. They have asked, is it really practical or feasible to train each and every task? Right? We know that there are infinite number of tasks, I suppose, and when we are saying that it is task-oriented approach, can we teach all the tasks? Even though variations of tasks can be taught, will it be sufficient? Will it suffice all the demands? So what they are asking is, there are, say for example, really there will be infinite number of ways you can do upper limb activities. There can be hundreds of activities you can do. Do you have to teach all the activities? Do you have to teach all the variations and things like that? This is a wonderful question, I think. The answer can be in 2 or 3 ways. I think I can answer it. The first one is, which I think is more appropriate than the other. The first answer, what I think is the solution for this kind of thing is getting a patient problem list. That is, I am unable to brush, I am unable to eat and things like that. Just write down those things. Pick the most important 5 or 4 or 3, whatever you are going to train, and then train those things. After they have some amount of proficiency in the top 5, then we can move to the next 5, something like that. Rather than, what I'm trying to say is, select the tasks which your patient thinks is better rather than what we can. Even in that, in different environments, they may have some struggle. So they can come back to you and say that, okay, I am able to take bath in my toilet, in my restroom, but if I go to my son's house, it is difficult. So then you can look into what are the parameters there which is different, and then try to solve it. But it is, as you have rightly pointed out, there are many variations. We will not be able to teach everything, right? The next answer is, there are some commonalities between lot of tasks, it seems. We just don't know the exact commonalities. So if you are able to train in some, say for example, eating, you may be able to do similar tasks like that, right? That is some other fine movement activities. So there may be some generalization, but at this point of time, the data is not sufficient to draw a conclusion which are tasks which have which can be generalized and which cannot be. We are not very clear. Right? So these are the two answers I think is for this question. I think this is a very wonderful question. Okay, the next question is, does task-oriented approach or functional activity-based approach time consuming? How can we manage case load, right? I don't know whether this is true, and I don't see it as time consuming. So I don't have any answer for this. I don't know. Again, this is a common question in stroke, but not in the case of task oriented. They are asking us, comparing to upper limb, the lower limb shows faster or much improvement. This is not really true. This is a sort of a pseudo recovery, I suppose, if you can call that. What we are trying to say is there are no fine movements in case of lower limb. So it looks like it has recovered very well, but in case of upper limb there is lots of fine movements. So it looks like it is recovering less, right? So it's a sort of a observational error rather than whether this is true physiologically. We are not very sure, right? Right. So the next question is also on context. Again, this I think is a good question in terms of which is specific to task oriented. Many times because of practical or environmental constraint, it is difficult to execute every task oriented exercise. What should be the guiding rule in such a scenario? I don't know about the guiding rule, but I have gone to homes of patients with stroke where the house was 8x6 or something like that, and they had a bed, and when the patient stood up and I was standing, there was no room for them to walk at all. I really didn't know what to do. I still don't know what to do in that case. I tried to make them come to my clinic, but they were unable to afford for an auto and then pay for me and things like that. So it was I really don't know how to solve that problem also. So when there is an environmental constraint, it is very difficult. In some places, we have overcome some environmental constraints with simple mechanisms. Say for example, one of the patients had to, I was teaching him community ambulation. So he has to come from his house, walk 2 or 3 stairs, and then get into the road, right? In the steps, what they have built, they didn't have railing, right? They didn't have railing, and they were unable to afford for a sort of a iron railing, and that too in the road also. They were struggling to do that. So what we did was we bought some chaukumaram, right? That's a wooden tree. You will get like a round thing. So we planked one on the road, another one like this. We tied it, and sort of a temporary arrangement, if you will, because it was on the road, right? It was basically on the platform. So we had to plank a wood like this, and then put a wood, and then we were using it as a railing. And after a few years, I just went there again. They have removed it now because he was able to walk like that. So there are some constraints we can overcome with ingenuity, and some constraints it is difficult. Especially in the late 90s and the early 2000s, a lot of people were having difficulty with the toileting activities. We used to add the hands-free washing. Now we have mostly everywhere. We used to get that and change it. So sometimes you need an ingenious method. Sometimes there is no really any solution. As far as the guiding rule, I am not very sure whether I have any guiding rule at this point of time. I really don't have, right? Okay, this is one of the common questions they ask every time I go and talk about task-oriented approach, whether we can allow trick movements or compensatory movements. So the question is, when using a TOE or functional activity based approach, to what extent can we allow trick movements to occur? Because they are, the next part of the question is, I think it's wonderful. As if it is practiced consistently, that is the trick movement or compensatory movement, they become permanent, right? They become permanent. That's the way they walk and things like that. So for me, there are again two answers. One is, if you are able to see the patient from the early stages, right, from the acute stage itself, if you are able to start your patient and start treatment, we can try to reduce the compensatory activities. We can try to reduce. But if they are coming into you in subacute stage and things like that, I am pretty sure you cannot change the compensatory mechanism. It is not possible. It is not possible to change any pattern, whether it is in the upper limb or in the lower limb. It is very difficult. Even in the acute stage, making patients do without compensatory movements is difficult, especially if the treatment, if the patient is moderately severe or severe. It is very difficult to make them do without compensation. So that is one part of it. That is difficult to change compensation or any patterns. The next thing is, that is, you have to think of compensation as a brain trying to attain a goal with its impairments or with its injury or things like that, right? So that is the only way it can do. It cannot do it in the sort of a normal way, if you will. So to worry about that, much of it is just worrying, because as I told you, it is difficult to change, right? So that's a sort of a vague answer for this. That is, compensatory movements cannot be avoided. So there is no way we can overcome this. Okay, as a clinician, is it imperative occasionally to think of other possibilities for treatment in view of a holistic approach for treatment? What they mean by holistic approach is what we call as an eclective approach, I suppose. Prakash told me a wonderful example. If I ask you to go and buy a phone, right? I suppose there are only two options for you now, either a smartphone with an Android or a smartphone with iOS, that is your Apple. Nobody is going to go and get an Android phone, because sometimes my smartphone will not work, so I will have a backup of non-Android phone, right? The old Nokia phone. What it means is, if we know that the smartphone is the best option for me, why am I going to buy a non-Android phone which was 100 rupees or 1000 rupees you can get it? Likewise, why am I going to have a treatment technique which was written in 1960 when we had very little understanding of neurology or physiotherapy, right? So I think eclective approach is for poorly educated people. This is a cartoon we made. Eclective approach is something like this. We take, we collect garbage from different places and then put it together, and we think that it will become something new or something like that. No, it becomes a bigger garbage, right? So adding roots approach or PNF or NDT with TOE is Ooh, nonsensical. Okay. The next question is, okay, we are going to give a task-oriented approach, but if I am going to make a patient walk, does he have to have control over sitting, or whether he has trunk balance and things like that, right? Is there an orderly way we want to go? Say, for example, in upper limb, do they need a scapular control for upper limb activity? All right. So the simple answer for this is not. It is wrong, right? It cannot be like that, because as you know that is the bottom line of task-oriented approach. That is, each task is controlled differently. The muscle activity is different. So for sitting, the muscle activity is different. For standing, the muscle activity is different. So you don't have to have trunk control to stand or scapular control to do this and things like that, right? It doesn't work like that. Each activity can be treated as a separate activity rather than going in a linear fashion, right? Next. This is a long question, but what are the markers in an individual with neurological disorders that may lead a therapist to decide that this is the limit of one's function? That is, they are basically asking is, when will you stop your treatment, right? So they have added that, is there a limit to improvement, progress in function, or if there is no limit, how can it be proven? This is crucial, as most of the therapists find it difficult when to wean off an individual with neurological disorders from therapeutics, be it TOE or any other treatment. This is a good question, because I don't want to say where I went. I went to a college for teaching stroke. They all seem to have the idea that plasticity is infinite, right? What it means is the brain can keep on changing after stroke, right? Which I find it ridiculous. It cannot. It can make small changes, but it cannot come back to the original position, right? So there are two answers to this also. The first answer is, after some time, right? We don't know. We don't have exact markers, right, when we want to stop. But after some time, you see a plateau in your patient, then it needs to, your patient has achieved whatever he can achieve, right? Afterwards, we can try, because there may be small incremental improvements, right? But the problem is the cost and benefit, whether they are able to afford that much of care afterwards for small incremental changes. That needs to be looked into. The next is, as we know that now we can have two types of stroke patient, I suppose, people who are improving and people who don't improve, right, in a simplistic sense. That is, in a chronic patient, you see that there is very little movement here, the shoulders are not moving much. The other movements are not, the elbow movements are very less. That kind of people are not going to achieve much. But if they are having some amount of activities, right, they have a potential to recover more. There is no question about it. But my basic concern is whether they are able to get a benefit which is larger than the cost. What I mean by cost is paying the therapist, staying in a place to come to a therapist, the auto charge or the car charge. All these things we have to take into consideration and see, where I think it seems to be, the benefit seems to be lesser than the cost, right? So this is a good question, because I think this is where we are at this point of time, where I know that I am teaching my patient to do a task-oriented approach. They are doing to some extent, but when I am not there, they are not practicing by themselves. I have made them walk inside the home, outside the home, but they are not participating. They don't actively go somewhere else and things like that. So that is common thing we see nowadays. We are in that place where we know that we are able to achieve activity in the ICF, but participation we are struggling. It is difficult to make the patient participates. Again, what should be done? I think you need a whole bunch of education. Look into the contextual factors, that is the environment where they have to go out or participate. What is the contextual factor which is inhibiting them, or they are acting as a barrier and things like that. But again, there are lots of emerging things. I'm not going into details of it, but there are a lot of emerging ideas from behavioral changes, how to bring about behavioral changes to your patient. You can look into those things like the cognitive behavioral approach, which can be modified and put here, or other behavioral approaches which can be used to make your patient participate more, right? So there are a lot of education theories which you can use. Right, this is whenever I go and talk about evidence-based people, somebody will always call me and tell us, we do tailor-made exercise to, I don't know what the tailor-made approach is, to be frank. Because by definition, task-oriented approach, at least in my definition of my book, is you have to teach a task which your patient thinks is important, right? So all task-oriented by definition should be tailor-made, right? Because as I told you in the earlier question also, if your patient wants to learn how to brush, that's a task. You select that task and give it. So by definition, all task-oriented or functional activity-based approach should be tailor-made. That is one way of. The other way is, by definition, what is tailor-made is, it is different from standard, right? You make specific for your patient. Say for example, if you are teaching sit to stand, right? Everybody teaches sit to stand from sort of a standard chair. Standard chair, the height of the chair will be anywhere from 16 to 18 inches. So if you are going lesser than that, that is making them sit on the ground, right, on the floor, or squat on the floor, these I think will be what we call as a tailor-made task-oriented exercise. One of the studies which we did and published, we trained the patient to sit on a low-lying stool because he was a shopkeeper who had a shoe shop, right? So you know that there is a small bench they will sit to put a shoe for you, right? So we we trained him to sit on a small chair. We also trained him to take shoes from the height with both the hands, right? A box-like structure like this, from a different height, with standing on the toes and taking it because the shelves were in a higher position. All these things we trained specifically for that patient because we don't mostly train for reaching up, right? So we can consider that as a tailor-made approach, right? Specifically, we also added, say for example, because he was a Muslim patient, we also added doing namaz and things like that, which again is slightly uncommon, or it's not given in a standard practice. So that can be considered as a tailor-made approach. The next question is, when giving functional activity based approach or TOE, what system changes, neural or muscular? As you know that the whole system changes, not just the brain, not just the muscle, not just the peripheral, the peripheral systems, not just the central system, whole system changes. Even your cardiovascular system also has to change. So everything changes, not just your neural and muscular. Okay. What's the next question now? Okay. What is the current status and future direction of TOE? The current status is, it is not as common as it should be, because this is task-oriented approach is the best evidence they have is for that. And the future direction is, we know, as I told you already, they have asked this question also. We know that we can improve participation, right? So the future direction is task-oriented approach plus behavioral change approach is what is going to happen in the next 10 to 20 years, I think. How to treat paresthesia followed by stroke? I don't know. What is paresthesia? I have to go to stroke. I don't know. Very uncommon. But the one thing I will tell you is, if you have any sensory problem in the hand, right? If you have sensory issues here, then it will have some impact on grasping and things like that. If you have sensory problems here, that is cutaneous sensory problem here, it doesn't matter at all. Right? And also the next thing you want to understand is, lot of sensory problems can be compensated very easily, right? If you don't have proprioception and things like that, it's easy to compensate with visual. So don't worry much about sensory problems, even though they are a problem. You don't have to be, you need to understand when it is going to be a problem. As for paresthesia, I don't know whether it affects stroke also, right? So these are the questions the audience have asked, and I hope that you are sort of happy with the answers which I gave you. If you are not, please comment on the comment section so that we can discuss more. Thank you so much.